Good day. Today we are discussing shock. Shock is a state of circulatory insufficiency that creates an imbalance between tissue oxygen supply or delivery and oxygen demand or consumption, resulting in end organ dysfunction. Reduction in effective perfusion may be due to a local or global delivery deficiency or utilization deficiency with suboptimal substrate at the cellular or subcellular level. The mechanisms that can result in shock are frequently divided into hypovolemic, cardiogenic, distributive, and obstructive. An understanding of the mechanisms of oxygen delivery and consumption is foundational to the treatment of shock. While the physiology is complex, familiarity with the basic principles, equations, and their interactions is essential. As noted in the cardiac output equation, cardiac output is determined by heart rate and stroke volume. Stroke volume is dependent on preload, afterload, and contractility. The mean arterial pressure demonstrates the impact that cardiac output has on MAP, which can also be estimated with the formula 2 times diastolic blood pressure plus systolic blood pressure divided by 3. This is important because there is a MAP threshold below which oxygen delivery is decreased. Systemic vascular resistance directly impacts MAP but also impacts afterload and thus cardiac output. The physiologic mechanism of oxygen delivery to peripheral tissues is described in the oxygen delivery equation. Patients in shock may initially have normal blood pressures or cryptic shock, yet have other objective signs of shock. It is from these basic equations that the concept of preload influencing stroke volume, which in itself influences cardiac output and DO2, has become fundamental in shock management. Tissue oxygenation is predicated on cardiac output being sufficient enough to deliver oxygenated hemoglobin to the tissues. Cardiac output is dependent on the interplay of cardiac inotropy, or the speed and shortening capacity of the myocardium, chronotropy, or heart contraction rate, and lusitropy, which is the ability to relax and fill heart chambers. Determinants of inotropy include autonomic input from sympathetic activation, parasympathetic inhibition, circulating catecholamines, and short-lived responses to an increase in afterload or the ANREPT effect, or heart rate, which is known as the Bowditch effect. Increases in the inotropic state help to maintain stroke volume at high heart rates. Under certain conditions, such as shock states, higher levels of epinephrine will be produced and reinforce adrenergic tone. Epinephrine levels are significantly elevated during induced hemorrhagic shock, but these levels subsequently reduce to almost normal levels after adequate blood pressure is restored. Previous studies have also shown that an acidotic milieu, which is common in shock, further compromises ventricular contractile force and blood pressure. Chronotropy and lusitropy are both influenced by sympathetic input. Norepinephrine interacts with cardiac beta-1 receptors, resulting in increased cyclic adenosine monophosphate. This leads to a process of intracellular signaling with an increased chronotropy and sequestration of calcium, leading to myocardial relaxation. So the physiologic equations are as follows. Cardiac output is equal to heart rate times stroke volume. Mean arterial pressure is cardiac output times systemic vascular resistance. Oxygen delivery is cardiac output times arterial oxygen content, or cardiac output times 1.39 times hemoglobin times oxygen saturation, all added to PaO2 times 0.0031. DO2, or oxygen delivery, is the amount of oxygen delivered to the tissues per minute. A normal value is 1000 milliliters of oxygen per minute. Arterial oxygen content is the amount of oxygen in the blood. So it is CaO2 is equal to 1.39 times hemoglobin times oxygen saturation, all added to PaO2 times 0.0031. So when you look at the oxygen delivery equation, just remove cardiac output there and you have arterial oxygen content. Oxygen consumption is cardiac output times arterial oxygen content minus venous oxygen content. So basically the difference between arterial and venous oxygen. And the amount of oxygen consumed by tissues each minute is equal to the difference in oxygen delivered to tissues and the oxygen returning from tissues to the heart. A normal value is about 250 milliliters of oxygen per minute. This formula ignores the small contribution from dissolved oxygen. The shock index is heart rate over systolic blood pressure. A normal value is 0.5 to 0.7. A persistent elevation of the shock index greater than 1.0 indicates an impaired left ventricular function as a result of blood loss or cardiac depression and carries a high mortality rate. When compensatory mechanisms fail to correct the imbalance between tissue supply and demand, anaerobic metabolism occurs and results in the formation of lactic acid. Lactic acid is rapidly buffered, resulting in the formation of measured serum lactate. Normal venous lactate levels are less than 2.0 millimoles per liter. Most cases of lactic acidosis are a result of inadequate oxygen delivery, but lactic acidosis occasionally can develop from an excessively high oxygen demand, such as in status epilepticus. In other cases, lactic acidosis occurs because of impaired tissue oxygen utilization, such as with septic shock or the post-resuscitation phase of cardiac arrest. Elevated lactate is a marker of impaired oxygen delivery or utilization and correlates with short-term prognosis of critically ill patients in the emergency room. Shock provokes a myriad of autonomic responses, many of which serve to maintain perfusion pressure to vital organs. Stimulation of the corroded baroreceptor stretch reflex activates the sympathetic nervous system, triggering arteriolar vasoconstriction, resulting in redistribution of blood flow from the skin, skeletal muscle, kidneys, and splanchnic viscera, an increase in heart rate and contractility that raises cardiac output, constriction of venous capacitance vessels which augments venous return, release of the vasoactive hormones epinephrine, norepinephrine, dopamine, and cortisol to increase arteriolar and venous tone, and release of antidiuretic hormone and activation of the renin-angiotensin axis to enhance water and sodium conservation to maintain intravascular volume. These compensatory mechanisms attempt to maintain oxygen delivery to the most critical organs, which are the heart and brain, but blood flow to other organs such as the kidneys and gastrointestinal tract may be compromised. The cellular response to decreased oxygen delivery or adenosine triphosphate depletion leads to ion pump dysfunction, influx of sodium, efflux of potassium, and reduction in membrane resting potential. As shock progresses, the loss of cellular integrity and the breakdown in cellular homeostasis result in cellular death. These pathologic events give rise to a cascade of metabolic features including hyperkalemia, hyponatremia, azotemia, hyper or hypoglycemia, and lactic acidosis. The clinical features of systemic inflammatory response syndrome, which may occur in the early phases of shock due to the physiologic changes mentioned above, these include two or more of the following features, which are a temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, a heart rate of more than 90 beats per minute, a respiratory rate of more than 20 breaths per minute, or a carbon dioxide tension of less than 32 millimeters mercury, a WBC count of greater than 12.0 raised to 10:9 per liter, less than 4.0 times 10 raised to 9 per liter, or more than 10% immature forms or bands. As systemic inflammatory response syndrome progresses, shock ensues, followed by the multi-organ dysfunction syndrome, which is manifested by renal failure, respiratory failure, myocardial depression, liver failure, and then disseminated intravascular coagulation. The fulminant progression from systemic inflammatory response syndrome to multi-organ dysfunction syndrome is determined by the balance of anti-inflammatory and pro-inflammatory mediators and the level of inadequate tissue perfusion. The four categories of shock can be described in terms of their respective physiologic changes and common causes, recognizing that overlap is common. So when it comes to hypovolemic, cardiogenic, obstructive, and distributive shock, hypovolemic shock has a decrease in preload, an increase in SVR, and a decrease in CO2, which are also found in obstructive shock. Distributive shock has decreased preload, increased systemic vascular resistance, and mixed cardiac output. And cardiogenic shock has an increase in preload, an increase in afterload, an increase in SVR, and a decrease in cardiac output. So, the etiologies of hypovolemic shock are hemorrhage, capillary leaks, gastrointestinal losses or burns, cardiogenic shock, have etiologies of myocardial infarction, dysrhythmias, heart failure, and valvular disease. Obstructive shock can be due to pulmonary embolism, pericardial tamponade, or tension pneumothorax, and distributive shock can be due to sepsis, neurogenic shock, or anaphylaxis. Hypovolemic shock occurs when decreased intravascular fluid or decreased blood volume causes decreased preload, stroke volume, and cardiac output. Severe blood loss or hemorrhage can cause decreased myocardial oxygenation, which decreases contractility and cardiac output. This action may lead to an autonomic increase in systemic vascular resistance. It can also occur due to volume loss from other etiologies. In cardiogenic shock, the left ventricle fails to deliver oxygenated blood to peripheral tissues due to variances in contractility as well as preload and afterload. Myocardial infarction is the most common cause of cardiogenic shock. Dysrhythmias are another common cause because they can lead to a decreased cardiac output. Bradyarrhythmias result in low cardiac output, and tachyarrhythmias can result in decreased preload and stroke volume. Obstructive shock is due to a decrease in venous return or cardiac compliance due to an increased left ventricular outflow obstruction or marked preload decrease. Cardiac tamponade and tension pneumothorax are common causes. In distributive shock, there's relative intravascular volume depletion due to marked systemic vasodilation. This is most commonly seen in septic shock. Compensatory responses to decreased SVR may include increased CO with increased contractility in heart rate and tachycardia. The concurrent decreased systemic vascular resistance results in a decreased preload and may hinder cardiac output overall. In sepsis, up to 40% of patients may have a transient cardiomyopathy characterized by decreased contractility and increased mortality. Anaphylaxis, adrenal insufficiency, and neurogenic shock are additional causes of distributive shock. So, when it comes to the pathophysiology of shock, we can sum it up through global tissue hypoxia, which leads to inadequate tissue perfusion or oxygenation in most cases, which can lead to gut barrier failure and oxygen delivery and utilization imbalances. Together, this forms a compensatory central response through the heart and sympathetic system with a malignant inflammatory response, a self-perpetuating cycle, shock, multi-organ dysfunction, and eventually death. When the clinical presentation of a patient in shock and the underlying cause may be quite apparent, such as with acute myocardial infarction, anaphylaxis, or hemorrhage, it may be difficult to obtain a history from patients in shock. Assistance with medical history from emergency medical services, family, or other sources may help determine the cause of shock, especially if the patient has comorbidities. Some patients in shock may have few symptoms other than generalized weakness, lethargy, or altered mental status. If the patient is unresponsive, we consider trauma as a primary or secondary complication. Shock is usually associated with systemic arterial hypotension with a systolic blood pressure of less than 90 millimeters mercury. Blood pressure is the product of flow and resistance, so mean arterial pressure is equal to cardiac output times systemic vascular resistance. Blood pressure may not drop if there's an increase in peripheral vascular resistance in the presence of decreased cardiac output with inadequate tissue hyperperfusion, making blood pressure an insensitive marker for global tissue hypoperfusion. Shock may occur with a normal blood pressure, and hypotension may occur without shock. No single vital sign is diagnostic of shock, and blood pressure is particularly insensitive in the presence of peripheral vascular disease, tachycardia with a small pulse pressure, or cardiac dysrhythmias. No single laboratory value is sensitive or specific for shock. Laboratory studies are driven by the clinical presentation and the presumptive cause. So, composite physical examination findings in shock include temperature, hypo or hyperthermia may be present. Endogenous hypothermia or hypometabolic shock must be distinguished from exogenous environmental hypothermia. Heart rate is usually elevated, but paradoxical bradycardia can be seen in shock states due to hypoglycemia, beta blocker use, and pre-existing cardiac disease. Systolic blood pressure may actually increase slightly when cardiac contractility increases in early shock and fall as shock advances. Diastolic blood pressure correlates with arteriolar vasoconstriction and may rise early in shock and then fall when cardiovascular compensation fails. Pulse pressure increases early in shock and decreases before systolic pressure begins to drop. Mean arterial blood pressure is often low, less than 65 millimeters mercury. CNS, you may have acute delirium or brain failure, restlessness, disorientation, confusion, and coma, secondary to a decrease in cerebral perfusion pressure. Skin or capillary refill can reveal pallor, pale, dusky, clammy skin with cyanosis, sweating, altered temperature, and an increased capillary refill time of greater than 2 to 3 seconds. Cardiovascularly, you may see neck vein distension or flattening depending on the type of shock. Tachycardia and arrhythmias may also be present, and an S3 may result from high output states. Decreased coronary perfusion pressures can lead to ischemia, decreased ventricular compliance, increased left ventricular diastolic pressure, and pulmonary edema. Respiratory manifestations include tachypnea, increased minute ventilation, increased dead space, bronchospasm, and hyper or hypocapnia with progression to respiratory failure. For the splanchnic organs, you may have ileus, gastrointestinal bleeding, pancreatitis, acalculous cholecystitis. Mesenteric ischemia can also occur due to low flow states. Renally, you may have a reduction in glomerular filtration rate. Renal blood flow redistributes from the renal cortex toward the renal medulla, leading to oliguria. Metabolically, you can have hyperglycemia, hypoglycemia, and hyperkalemia. As shock progresses, metabolic acidosis occurs with concurrent attempted respiratory compensation. So when it comes to imaging, an AP view on chest X-ray is often used in the evaluation of unstable patients to avoid transporting the patient during resuscitation. So we look at the heart size, presence of pulmonary edema, free air under the diaphragm, pneumothorax, infiltrates, or effusions in the chest X-ray. Ultrasound is also used for developing a differential diagnosis, assessing volume status, defining cardiac function, and assisting with procedures. So you could also use ultrasound to assess left ventricular ejection fraction, and it could assist with determining the cause of shock. So initial diagnostic studies to evaluate a patient in shock include CBC with differential, electrolytes, glucose, calcium, magnesium, phosphorus, BUN, creatinine, serum lactate, EKG, urinalysis, chest radiograph, coagulation studies such as prothrombin time, PTT, and INR, arterial blood gas with measured pH, carbon dioxide, and oxygen levels, hepatic function panel, blood cultures, urine cultures, suspicious wound cultures, quantitative sputum cultures, cortisol level, pregnancy tests, and the CD of the chest, abdomen, or pelvis as indicated by history and physical examination. So, although CT is an accurate and non-invasive approach for detecting internal pathology, patients must travel from the emergency room to the radiology department, which may be unadvisable in unstable shock. Hemodynamic monitoring helps assess the severity of shock and the response to treatment. So this includes pulse oximetry, electrocardiographic monitoring, and non-invasive blood pressure monitoring. And when it comes to early treatment, we have the ABCDE tenets of shock resuscitation. And here we establish airway, control the work of breathing, optimize circulation, assure adequate oxygen delivery, and achieving endpoints of resuscitation. Airway control is best obtained through endotracheal intubation. Sedatives used to facilitate intubation may cause arterial vasodilation, venodilation, or myocardial suppression and may result in hypotension. Positive pressure ventilation reduces preload and cardiac output. The combination of sedative agents and positive pressure ventilation will often lead to hemodynamic collapse. To avoid this unwanted situation, we initiate volume resuscitation and vasoactive agents before intubation and positive pressure ventilation. Control of breathing is required when significant tachypnea accompanies shock. Respiratory muscles are significant consumers of oxygen during shock and contribute to lactate production. Mechanical ventilation and sedation allow for adequate oxygenation, improvement of hypercapnia, and assisted controlled synchronized ventilation. These all decrease the work of breathing and improve survival. It is also essential to consider the patient's compensatory minute ventilation prior to intubation and prior to starting mechanical ventilation to ensure appropriate initial settings are selected. We also obtain an arterial blood gas to evaluate acid-base status, oxygenation, and ventilation. Neuromuscular blocking agents should be considered to further decrease respiratory muscle oxygen consumption and preserve oxygen delivery to vital organs, especially patients are severely hypoxemic due to acute respiratory distress syndrome. Circulatory or hemodynamic stabilization begins with intravascular access, and the Trendelenburg position does not improve cardiopulmonary performance compared with the supine position. It may also worsen pulmonary gas exchange and predispose to aspiration. Passive leg raising above the level of the heart with the patient supine may be effective. If passive leg raising results in an increase in blood pressure or cardiac output, fluid resuscitation is indicated. It should begin with isotonic crystalloid, and the amount and rate of infusion are determined by an estimate of the hemodynamic abnormality. Most patients in shock have either an absolute or relative volume deficit. The exception is the patient in cardiogenic shock with pulmonary edema. We administer fluid rapidly over 5 to 20 minutes in set quantities of 500 or 1000 ml of normal saline and reassess the patient after each bolus. Patients with a modest degree of hypovolemia usually require an initial 20 to 30 milliliters per kilogram of isotonic crystalloid, as is suggested in the 2012 Surviving Sepsis Campaign Guidelines. However, there is few data to support this uniform recommendation, and fluid volume should be individualized to each patient. More fluids are needed for profound volume deficits. It is common for patients in septic shock to receive 6 liters of crystalloid in the first 24 hours of hospital care, and for large fluid volumes, we consider using lactated ringers or plasmolite to avoid hyperchloremic metabolic acidosis. Vasopressors are used when there has been an inadequate response to the volume resuscitation or if there are contraindications to volume infusion. Vasopressors are most effective when the vascular space is full and least effective when the vascular space is depleted. Patients with chronic hypertension may be at greater risk of renal injury at lower blood pressures. However, in others, there appears to be no mortality benefit in raising MAP above the 65 to 70 millimeters mercury range. So, we also assure adequate oxygen delivery. It is important in restoring the balance of oxygen supply and demand to the tissue in the oxygen consumption equation. A hyperadrenergic state results from the compensatory response to shock, physiologic stress, pain, and anxiety. Shivering frequently results when the patient is unclothed for examination and then left inadequately covered in a cold resuscitation room. The combination of these variables increases VO2, or oxygen consumption. Pain further suppresses myocardial function, further impairing oxygen delivery and oxygen consumption. Providing analgesia, muscle relaxation, warm covering, anxiolytics, and even paralytic agents when appropriate decreases this inappropriate systemic oxygen consumption. So, when it comes to the vasoactive agents that are being used, the butamine increases cardiac contractility more than it vasoconstricts or vasodilates, and it increases cardiac output. Dopamine increases both cardiac contractility and vasoconstriction at the same degree, but at different doses. For cardiac contractility, it's at 2.5 to 5 micrograms per kilogram per minute, and for vasoconstriction, it's at 5 to 20 micrograms per kilogram per minute, and for vasodilation, it's weaker at 0.5 to 2.0 micrograms per kilogram per minute, and cardiac output usually increases. Epinephrine has more of a cardiac contractility and vasoconstriction effect than vasodilation, and the cardiac contractility range is 0.5 to 8 micrograms per kilogram per minute. For vasoconstriction, it's greater than 8 micrograms per kilogram per minute, and cardiac output is increased. Isoproterenol has great effects on cardiac contractility and vasodilation and does not vasoconstrict. It also increases cardiac output. Norepinephrine is more of a vasoconstrictor. It has no vasodilatory effect, and it has weak cardiac contractility effect with a slight increase in cardiac output. Phenylephrine has a vasoconstrictive effect and no cardiac contractility or vasodilation effect. It also decreases cardiac output. Vasopressin is a vasoconstrictor and it does not have any effect on cardiac output. Once blood pressure is stabilized through optimization of preload and afterload, oxygen delivery can be assessed and further manipulated. We restore arterial oxygen saturation to greater than or equal to 91%. In shock states, we consider a transfusion of packed red blood cells to maintain hemoglobin at greater than or equal to 7 to 9 grams per deciliter. If cardiac output can be assessed, it should be increased using volume infusion or inotropic agents in incremental amounts until venous oxygen saturation and lactate are normalized. Sequential examination of mixed venous oxygen saturation is a method to assess adequacy of a patient's resuscitation. We also examine lactate levels. So, The endpoints of resuscitation, or the goal of resuscitation, is to use hemodynamic and physiologic values to guide therapy in order to maximize survival and minimize morbidity. No therapeutic endpoint is universally effective, and only a few have been tested in prospective trials with mixed results. Hypotension at emergency presentation is associated with poor outcomes. Non-invasive parameters such as blood pressure, heart rate, and urine output may underestimate the degree of remaining hypoperfusion and oxygen depth. So, the use of additional physiologic endpoints may be informative. A goal-directed approach of MAP greater than 65 mm mercury, central venous pressure of 8 to 12 mm mercury, SCVO2 of greater than 70%, and urine output of greater than 0.5 milliliters per kilogram per hour during emergency resuscitation of septic shock has been shown to decrease mortality, but which of the metrics accounts for the mortality decrease remains in question. So, colloids are, due to their higher molecular weight, they stay in the intravascular space significantly longer than crystalloids. The intravascular half-life of albumin is 16 hours versus 30 to 60 minutes for normal saline and lactated ringer solution. Resuscitation with crystalloids requires 2 to 4 times more volume than colloids. The outcome advantage between crystalloid and colloid continues to remain unresolved in sepsis despite multiple studies. So, questions to answer if there's persistent shock or hypotension is if the patient is appropriately monitored, if there's an equipment malfunction, if vasopressor infusions are working, and if they're in the correct dose. We also check if mentation and clinical appearance match the degree of hypotension, if the patient is adequately volume resuscitated, if the patient has a pneumothorax after placement of central venous access, if the patient has a occult penetrating injury, if there's been bleeding from a ruptured spleen, large vessel aneurysm, or ectopic pregnancy, if the patient has adrenal insufficiency, if the patient is allergic to medication just given, if there is cardiac tamponade in a dialysis patient or cancer patient, and if there is associated acute myocardial infarction, aortic dissection, or pulmonary emboli. Bicarbonate administration shifts the oxygen hemoglobin dissociation curve to the left, impairs tissue unloading of hemoglobin-bound oxygen, and may worsen intracellular acidosis. However, many clinicians remain uncomfortable with withholding bicarbonate if the pH is less than 7.00. And for fluid therapy, we have crystalloids and colloids as mentioned earlier. Normal saline is slightly hyperosmolar, containing 1.54 mg per liter of both sodium and chloride. There's a risk of inducing hyperchloremic metabolic acidosis when given in large amounts due to relatively high chloride concentrations. Lactated ringers has lactate, which can accept a proton and subsequently be metabolized to carbon dioxide and water by the liver, leading to release of carbon dioxide in the lungs and excretion of water by the kidneys. Lactated ringers results in a buffering of the acidemia that is advantageous over normal saline. There's a theoretical risk of inducing hyperkalemia in patients with renal insufficiency or renal failure due to small potassium content. Albumin is derived from human plasma, and there's no outcome difference whether colloids or crystalloids are used. And hydroxyethyl starch is a synthetic colloid derived from hydrolyzed amylopectin. It should be avoided in sepsis. There are harmful effects such as renal impairment at recommended doses and impairing long-term survival at high doses, coagulopathy, and bleeding complications from reduced factor VIII and von Willebrand factor levels, and impaired platelet function. So when it comes to fluid and blood resuscitation in traumatic shock, circulatory shock has a very high mortality, and severe hemorrhage after injury may also occur. So it is important for us to give fluid and blood resuscitation in order to restore intravascular volume sufficient to maintain oxygen carrying capacity and tissue perfusion for adequate cellular oxygen delivery and prevent or correct derangements in coagulation. Circulatory shock is a state of impaired oxidative metabolism and homeostasis due to inadequate oxygen delivery to meet metabolic demand and hypoperfusion, leading to inadequate cellular waste removal. Acute shock triggers a complex range of physiologic responses that compensate for intravascular volume loss and maintain perfusion to the most important vascular beds. Shock also produces a global insult to the vascular endothelium that activates the coagulation and inflammatory systems. When uncorrected, coagulopathy, additional inflammation, and organ system damage result. Coagulopathy is observed in trauma victims and is termed trauma-induced coagulopathy, and it is ascribed to a combination of factors beginning with loss of coagulation factors from hemorrhage, followed by hemodilution from crystalloid resuscitation, and then exacerbated by acidosis, evidenced by a base deficit, and hypothermia that occur during the course of ongoing hemorrhage and resuscitation. These same principles also apply to other causes of shock. However, acidosis does not by itself have a significant effect on coagulation until the pH decreases below 7.0. The lethal triad of hypothermia, hemodilution, and acidosis can be viewed as a partially iatrogenic thing based on the type of resuscitation provided. Factors exacerbating trauma-induced coagulopathy, including hyperfibrinolysis and clotting factor and platelet consumption or dysfunction, are related to the degree of injury and hemorrhage. Early trauma-induced coagulopathy is characterized by anticoagulation and hyperfibrinolysis, likely modulated through the protein C pathway. Endothelial damage associated with trauma or sepsis stimulates an increase in thrombomodulin expression on the endothelium that complexes with thrombin and in turn activates protein C. So when it comes to fluid spaces in the body, total body water is 60% of body weight, intracellular fluid is 40% of body weight, extracellular is 20% of body weight, and within the extracellular fluid compartment, interstitial fluid is 15%, intravascular is between 7 to 8%, with plasma at 4.0 to 4.5% and red blood cells at 3.0 to 3.5%. The clinical appearance of acute traumatic shock is variable and depends on the cause, rate, volume, and duration of volume loss or bleeding, the presence of other acute disorders, the effects of current medications, and the patient's baseline physiologic status. So, patients with excellent baseline physiologic status, such as young athletes, may have a robust compensatory response to hemorrhage, that they appear stable and do not manifest tachycardia or hypotension even with large blood volume loss. Signs of peripheral hypoperfusion and subtle mental status alterations may be the only clues that severity of hemorrhage is greater than predicted based on hemodynamic parameters. Elderly patients may not develop tachycardia due to underlying heart disease or medications such as beta-adrenergic blockers. Bradycardia or lack of tachycardia may occur in about 30% of patients with intra-abdominal hemorrhage from increased vagal tone in response to hemoperitoneum. In a pregnant trauma patient, compression of the inferior vena cava by the gravid uterus can decrease central venous return and worsen hypotension and tachycardia in the setting of less severe hemorrhage. Vital signs offer little value unless they are in extreme low ranges. Arterial blood pressure does not adequately reflect cardiac output or regional perfusion. There's a biphasic relationship between oxygen consumption and oxygen delivery. While this relationship exists for the body as a whole, it also exists for each individual organ system and is largely mediated by the microcirculation. Oxygen debt develops in tissues or organs when oxygen delivery does not meet the metabolic demands and represents the amount of extra oxygen that is needed to metabolize accumulated products of anaerobic metabolism once perfusion is restored. Oxygen debt is the accumulation of multiple oxygen deficits over time and is a measure of whole body ischemia. Oxygen debt is the only physiologic measure that has clearly been linked to both mortality and even morbidity in the form of multiple organ failure after shock. The degree of oxygen debt incurred after injury has also been linked to inflammation. So when it comes to treatment of traumatic shock, resuscitation begins in the pre-hospital setting, and we have to restore intravascular volume to reverse or limit systemic and regional hypoperfusion. We maintain oxygen carrying capacity so that tissue oxygen delivery meets demand and limit ongoing blood loss and prevent the development of coagulopathy. From the moment resuscitation begins, we prevent the development of hypothermia by keeping the patient warm and administering warmed IV fluids and blood products. Endogenous hypothermia occurs when heat production from cellular respiration is decreased by hypoperfusion and inadequate tissue oxygen delivery. So, as always, we need to give airway control, ventilation, and oxygenation. We need to establish vascular access and monitoring, and hemostatic resuscitation and hypotensive resuscitation is also given. Isotonic crystalloid solutions are also administered. Colloid solutions may also be given. And In this case, an argument that favors the use of colloids has been the concern that extravascular shift or third spacing of infused crystalloid solutions has potential adverse effects, including pulmonary interstitial edema with impaired oxygen diffusion and intra-abdominal edema with diminished bowel perfusion. However, pathologic conditions such as hemorrhagic shock and sepsis lead to increased vascular permeability that can allow for eventual extravascular leakage of larger colloid molecules. Hypertonic saline has been proposed as a potential crystalloid alternative that would limit the tissue edema effects that are often in concern. It has anti-inflammatory and immunomodulatory effects with demonstrable decrease in lung and interstitial injury in animal models. And packed red blood cells are the most commonly transfused blood product, and using only packed RBCs in the patient with traumatic shock and ongoing bleeding without plasma and platelets will do little to promote hemostasis and may not restore tissue oxygenation. So we also give fresh frozen plasma and platelets, and massive transfusion protocols are administered or they are used when there is a requirement for more than 10 units of packed RBCs within the first 24 hours of injury. It is not a substitute for definitive surgical hemostasis, but enhances the ability to achieve surgical hemostasis and to limit complications. Packed RBCs and fresh frozen plasma contain citrate that can complex calcium, which produces life-threatening hypocalcemia. Most massive transfusion protocols include the administration of calcium and monitoring of ionized calcium. Calcium chloride is preferred over calcium gluconate because a well-perfused liver is required to liberate more free calcium from calcium gluconate. And that's all. Our source is Tintinalli's Emergency Medicine. Thank you.